these tests you have to know perfectly. Biochemical blood test can show us affection of practically every organ in our body. That's why this is a standard test for any patient. How to call condition when something is elevated in biochemical blood test. For example, glucose, elevation of glucose.
Hyperglycemia.
Hyperglycemia. Hyper something anemia. Decreased one.
Hypo.
Hypo something
Glycemia.
anemia. Hypoglycemia, if we speak about glucose. So first of all, when you will assess it, you need to find which indicators are increased or decreased and tell names of these symptoms. Next, you have to combine symptoms to the syndromes and suspect possible disorders. First indicator in our case is glucose. It's glucose. So increased one is hyperglycemia, decreased one is hypoglycemia. What is disease? If it is hyperglycemia, diabetes mellitus. What about hypo?
Starvation.
Starvation, malnutrition. What else?
Liver problem.
Liver problems now.
Pancreatic amylase.
What about pancreatic?
Enzymes
Hormonal
amylase.
imbalance.
Amylase.
If there is pancreatitis, it will lead to hyperglycemia. It will lead to first type of diabetes mellitus. Why level of glucose could go down?
Too much used.
Too much?
Used like in what?
Increased physical activity.
Yeah,
thyroid.
if patient is after starvation and if patient will have physical activity or emotional stress, exam, most of students fall down before exam or when they look at surgery.
Hyperthyroid.
Hyperthyroidism, hypo, hyper.
Hyper.
Mm,
Hyper mean
so
used.
it's maybe, but not typical. Which hormone regulate?
Insulin.
Insulin.
Hyperinsulinemia.
Hyperinsulinemia. Why does it possible?
Tumor in pancreas.
Which one?
Beta cell.
And this tumor is named insulinoma.
Insulin.
Tumor which produce insulin. And also injections of insulin or anti-diabetic drugs intake. If patient with diabetes mellitus will inject insulin and will forget or will not have a time to eat, hypoglycemia will appear and even coma can happen. Okay, next indicator is urea and creatinine. Machivina is urea, creatinine. These two connections are and stages of which macro elements?
Protein.
Proteins. So destruction of proteins goes with urea and creatinine. Urea and creatinine have to be removed with kidneys. So if there is increased level of urea and or creatinine, hyperuricemia and hypercreatininemia, it is kidneys failure. One more indicator of kidneys failure is potassium, kali in Russian.
Increased potassium.
Increased potassium, yeah. What if level of urea and creatinine are decreased? Liver problems. So liver do not produce these connections. It is part of liver hepatocellular incompetence syndrome. This syndrome we will make summary of the syndrome later. Next indicator is uric acid. What is it? What is connection uric acid?
Urea.
And stage of what? Of which metabolism? Purines. So nucleic acids and stage metabolite. Uric acid elevates if there is which which disease?
Gout.
Gout. Next one, total protein and two fractions of proteins, albumins and globulins. How to call increased protein?
Hyperproteinemia.
Protein.
Increased one?
Hyperproteinemia.
Hypoproteinemia. Why hypoproteinemia possible? Why does it possible?
Decrease intake.
Hypo.
Decrease intake.
No,
Or
liver.
the-
Decreased intake of proteins. Okay, what else?
Or the
Liver.
enzymes. Enzyme deficiency. The protease enzyme deficiency.
So let's call these reasons like alimentary problems. Malnutrition, maldigestion, small intake of protein, starvation, and etc. Everything what is related with digestion. What about liver?
Doesn't produce.
If liver does not produce protein, so it is part of hepatocellular incompetence. What else?
Cellular.
Hepatocellular
Hepatocellular
incompetence. And one more reason? There are more reasons, but one more the most typical.
Tumors.
Tumors maybe, but
The-
not the most typical reason. So first reason was intake of protein. Second reason is abnormal synthesis of proteins, and what else? is possible?
Infection.
Kidney. No.
What is with kidneys?
That is.
Damage. The
No, this is
Damage of nephrons. Reabsorption is not about proteins. Filtration is about proteins. If proteins will be filtrated with kidneys, patient will lose a lot of proteins, and it will lead to hypoproteinemia. It is nephrotic syndrome when patient lost a lot of proteins with urine, kidney disorders. Okay, albumins are transport type of proteins, and reasons to have decreased albumins are same. Total protein, why could it be increased?
hyperproduction.
Hyperproduction? Very, very rare. Practically impossible. Our organism use so many proteins so necessary.
Deficiency is related with glucose intake.
And that's why proteins will be increased.
Inflammation.
Genetic disorders.
Inflammation could affect globulins, and because of globulins, total protein can be increased. But mostly in inflammation, amino acids which are present in the pores will be used for production of acute phase proteins, globulins, and etc. And that's why total proteins will be used, and they will go down. In chronic infections, in severe infections like a sepsis, we will see hypoproteinemia because of increased using of proteins for inflammation. But why is it possible to see increased proteins?
Obesity.
Obesity, no.
Only in
It's rare disease, that's why you maybe don't know about it. There are disorders of bone marrow when immune system produces a lot of abnormal immunoglobulins. Example of this disease is multiple myeloma. There is macroglobulinemia, there are another disorders with overproduction of abnormal immunoglobulins. They accumulate a lot, and that's why total level of proteins will be increased. Globulins. Globulins are inflammatory proteins, first of all. Alpha and gamma globulins are the most important. proteins elevate, patient can have a syndrome of inflammation, mesenchymal inflammation syndrome. Next indicators: thymologia probe, thymol test, serum mucoid, gaptoglobin, C-reactive protein. Additional tests which are not written in this card, but which we can test, is fibrinogen. All these connections are acute phase proteins plus globulins. Acute phase proteins are syndrome of mesenchymal inflammation. Any inflammation in patient's body, tonsillitis, pancreatitis, hepatitis, enteritis, colitis, anything will lead to elevation of acute phase proteins, and we will see syndrome of mesenchymal inflammation. Next one, rheumatoid factor. What is it? Do you know?
Rheumatic fever.
It could be rheumatic fever, not exactly, but it's possible to meet it in rheumatic fever. Rheumatoid factor is antibodies against of human antibodies. They are outer antibodies against of our own antibodies.
Autoimmune.
It will look like immune complex of antibody plus antibody. These factors are factors of rheumatoid arthritis.
Rheumatoid.
Rheumatoid arthritis. There is rheumatic disease, rheumatism. There is rheumatoid arthritis. They have some similarities, that's why names are close to each other, but disorders are different. And pathogenesis is different. Rheumatic fever is disease which caused by beta hemolytic streptococcus, but disease is autoimmune. Rheumatoid arthritis is only autoimmune disease. And these immune complexes, antibodies plus antibodies, can go to connective tissue, can go to joints, and they will lead to inflammation. In some cards on the exam you can meet acute rheumatic fever markers too. You can find mesenchymal inflammation plus anti-streptolizin O.
Doctor, can you repeat what is rheumatoid factor?
Antibodies against of human antibodies. Autoantibodies against of immunoglobulins. Streptococcal infection. And as a marker we can see antibodies against of streptococcal antigens. Anti-streptolizin O.
How can we diagnose the rheumatoid factor?
Rheumatoid arthritis.
Yeah,
First of all, we will see a patient with arthritis.
arthritis.
Arthritis can affect big joints and small joints too. Rheumatic disease affect only big joints. Rheumatoid arthritis can affect everything. The most typical locations are fingers of hands. And this disease, if it will progress, can lead to ankylosis of joints, and we can see deformation of patient's hand and fingers. In lab tests, we can see mesenchymal inflammation. Rheumatoid factor is possible. We can find circulative immune complexes, and also we need to prescribe specific markers for this disease. There is marker anti-CCP, anti-citrulline cellular something. I forgot how to pronounce everything. This marker is very specific for this disease. Most of patients have positive anti-CCP. If we found anti-CCP, it is rheumatoid arthritis exactly. If we don't found it, it doesn't mean the disease is excluded. So mostly clinical picture, results of lab tests and plus X-ray examination of joints. But it's not our task. In our chair we don't study rheumatoid arthritis. We will study it in the 5th year. Okay, next indicator in our card. Total cholesterol. Below it, beta lipoprotein. If we need, also we can prescribe high density, low and very low density lipoproteins and triglycerides. We need this test to confirm atherosclerosis. Increased level of cholesterol is hypercholesterolemia. It could be in atherosclerosis, in obesity, and obesity will lead to atherosclerosis. Also, we can see it in cholestasis. Cholestasis is compression of bile ducts. Why does it increase? Does it decrease? Why can we detect decreased level of cholesterol?
Starvation.
Malnutrition maybe, starvation maybe. If we speak about pathology. What are sources of cholesterol in our body? How can we get a cholesterol?
Membrane.
There are two sources of cholesterol in our body.
Diet,
First one is diet
liver,
and liver. Liver makes synthesis of cholesterol.
Storage.
So if there is liver incompetence, cholesterol will not be produced. So decreased level of cholesterol could be because of liver incompetence, hepatocellular incompetence. About lipoproteins. So there are high density, low and very low density lipoproteins, which are atherogenic, which are anti-atherogenic.
high density is
Anti-atherogenic, low and very low are atherogenic or pro-atherogenic. So if we test our patient and we see increased level of high density and low density and very low are normal or decreased, patient does not have risks of atherosclerosis. If opposite, patient has very high risk of atherosclerosis. We do these tests in patients with cardiovascular system disorders. Next, in our cards, bilirubin, total and direct. Why bilirubin could be increased? Jaundice. What kinds of jaundice do you know?
Hepatic, pre-hepatic, post-hepatic.
Okay.
And also
Which
gluten.
cholesterol increases in perihepatic jaundice? Direct or indirect?
pre-hepatic.
In
Pre-hepatic.
perihepatic. Do I need to show you metabolism of bilirubin to understand jaundice?
Yes. We know what to do.
What is source of bilirubin in our body?
RBC.
RBC after lysis will release hemoglobin. Hemoglobin contains two parts, chem and globin. Which part is source of bilirubin? Heme, through the some stages, will produce bilirubin. Which one?
In
Unconjugated or indirect? Why does it name unconjugated?
it's not,
Not
bind
bound
with
with the protein.
Not with protein. It's not protein. It's carbohydrate. Which one?
something bound. Something bound.
Yeah.
Glucuronic acid. Why does it name indirect?
Not sunflower.
Insoluble.
Biochemistry. We don't need it. Why do we need to remember it? Indirect, it is named because of its fatty soluble connection, and it cannot be in the blood itself. It could be in the blood only in connection with albumin. So indirect bilirubin is connection of bilirubin plus albumin. Albumin transports this bilirubin. To detect level of indirect bilirubin, we need two steps reaction. First step is to remove albumin, and second step is detection of bilirubin. To detect direct bilirubin, we need one step reaction. We don't need to remove albumins. That's why this reaction is indirect reaction, and we name this bilirubin indirect one. For direct bilirubin, there is only one step direct reaction. Two steps reaction with diazoreactive of Ehrlich's or something like this. You've studied in biochemistry. Why you don't remember?
We don't know.
That is lieutenant.
It was in biochemistry. You've passed it. So,
We don't know how it
bilirubin goes to the liver. And in liver, bilirubin will react with glucuronic acid under actions of some enzymes. And when bilirubin will add glucuronic acid, it will be named bilirubin direct. How direct bilirubin could be removed from liver?
Via bile.
By bile. It will go to the bile, and with bile it will go to intestines. In intestines, it will change configuration a little and will be named in another way. How? Stercobilin. Stercobilin make a brown color of feces, and it will have to be removed with the feces. But part of stercobilin will be absorbed to the blood, and this stercobilin will go to the kidneys and will be removed with the urine. In the urine, it will have another name. Which one? Urobilin. And that's why urine is yellow. Not because of urea, because of urobilin. So, if there is pre-hepatic jaundice, there is increased hemolysis. Increased hemolysis will lead to increased production of indirect bilirubin. Indirect bilirubin will go to the liver. Conjugation will happen normally. There will be increased production of direct bilirubin, which fully will be removed to the feces. There is stercobilin. Stercobilin will be produced, that's why feces are with normal color. More stercobilin will be absorbed back to the urine, and urobilin will be increased. That's why liver urine will be darker than normal, dark yellow urine. In the blood, we will see increased total bilirubin because of indirect one. direct bilirubin is normal or close to normal, feces are normal, urine test will show us urobilin present, absence of bilirubin. Next case, hepatic jaundice. Hemolysis is normal. Liver will have slower metabolism of bilirubin. That's why level of bilirubin in the blood, indirect bilirubin, will increase. In the liver, there is cytolysis, destruction of hepatocytes. Components of hepatocytes will go to the blood. One of the components is direct bilirubin. That's why direct bilirubin will go to the blood and will increase too. So we will see increased both direct and indirect bilirubin. Part of direct bilirubin anyway will go to the feces. Feces are with normal color. Urobilin will be produced, and urobilin will be present in the urine. But also, direct bilirubin will be removed with the urine too. And we will see both presence of bilirubin and urobilin in the urine. When we speak about bilirubin in the urine, we mean direct bilirubin, because of it is water-soluble connection. Only this bilirubin can be in water and urine. Indirect one cannot be. So, hepatic jaundice is increase of total bilirubin because of elevation of both direct and indirect one. Feces are with normal color. Urine contain both bilirubin and urobilin. Next, post-hepatic jaundice. There is block in bile duct. Direct bilirubin will be produced, but cannot be released to the bile. That's why direct bilirubin with another bile components will go to the blood. With the blood flow, bilirubin will go to the urine and will be removed with the urine. Stercobilin will not be produced. Feces are colorless. Because of absence of stercobilin, urobilin will not be produced. That's why in the blood we will see increased amount of total bilirubin because of direct. Feces are pale or colorless. Urobilin in the urine is absent, bilirubin is present. In all three cases, urine is dark. In hepatic and post-hepatic jaundice, because of presence of bilirubin, urine is dark brown or practically black, very, very dark urine. In prehepatic jaundice, there is only urobilin. That's why urine is dark yellow, darker than normal, but not brown. It is about jaundice. So jaundice we can test in coprological studies. We will see change color. In biochemical blood test, we will see increased. We can conclude what kind of jaundice is it. Transferase and aspartate aminotransferase, ALT, AST. These enzymes are specific enzymes for liver, heart, and some in other organs. So, but we use them first of all to diagnose liver disorders. If there is cytolysis, destruction of hepatocytes, we will see elevation of these enzymes. ALT and AST will elevate. ALT elevates more than AST if it is acute liver disease. AST elevates more than ALT if it is chronic liver disease. In heart disorders, AST greater than ALT2. And next students ask a question, how to differentiate? You don't assess patient using only lab tests. You assess patient by patient's complaints, anamnesis, results of physical examinations. If patient came to you with chest pain, it is heart disease. If patient come to you with abdominal pain, dyspepsia, enlargement of abdomen, it is liver disease. So, not only lab tests, markers of disorders. You have to remember just that AST is greater than ALT if it is heart disorders or chronic liver disorders. For clinical practice, if your patient came to you with chest pain, you check lab tests, check cardiac markers, and you see that AST is smaller than ALT. In this case, you have to suspect concomitant liver disease. So patient has
liver disease and heart disease.
yeah, normally for heart problems is AST elevation more than ALT. Both will be elevated, but AST is greater. But if you see that ALT is greater than AST, you have to suspect additional problems. Next, indicator gamma glutamyl transpeptidase or GGTP. GGTP is marker of cholestasis. It's component of bile. Next indicator is alpha amylase. Alpha amylase is enzyme of pancreas. It will increase if it is pancreatitis. Next indicator, щелочная фосфатаза in Russian, alkaline phosphatase in English, or ALP. Alkaline phosphatase is main marker of cholestasis. It's component of bile too. Next indicators, chlorides, calcium, in Russian kali it is potassium, natri in Russian is sodium, and phosphor. These are ions, and we use assessment of ions to check kidneys problems or to correct infusion therapy. To know which ions do we need to add or to do something else. Next ion, which we can test, is iron. Сывороточное железо in Russian, it is iron of blood serum. And next indicator, last in the table, is OGSS. It is iron binding capacity of blood serum.
Doctor, don't we check hemoglobin in this?
Hemoglobin is common blood test. Iron binding capacity of blood serum. So iron and iron binding capacity of blood serum, and also ferritin, also transferrin, we have to check to see signs of iron deficiency or opposite, overdose of iron. If there is increased iron, it could lead to hemochromatosis. Diseases named hemochromatosis. Iron can go to internal organs and affect them. If patient has decreased iron, it can lead to anemia, but it is iron deficiency. Iron deficiency could be of different types. It could be iron deficiency with anemia, or it could be hidden iron deficiency. When patient does not have clinical signs, but the pore is empty. That's why we need so many markers. Iron itself shows level of iron in the patient blood, but it does not show us how many iron in the depot. OGSS, iron binding capacity of blood serum, shows us how much iron patient serum can take more. If level of iron decreases, iron binding capacity increases. Blood can take more iron. Ferritin is a depot of iron. Ferritin increases if there is a lot of iron, ferritin decreases if depot is empty. In hidden iron deficiency, iron of blood serum could be normal, but ferritin is decreased. And transferrin is transport type of iron. It's transport protein to transport iron. If there is iron deficiency, transport proteins increase. That's why we will see increased amount of transferrin. So in iron deficiency we will see decreased iron, increased iron binding capacity of blood serum, decreased ferritin and increased transferrin. In overdose of iron, we will see everything opposite. Increased iron, decreased iron binding capacity, increased ferritin, decreased transferrin. There are some additional indicators which we can prescribe. LDH, lactate dehydrogenase. It's non-specific connection which is present in liver, heart, brain. We can see it in cytolysis, we can see it in heart disorders. Next one connection.
Creatine phosphorylase.
Creatine phosphokinase, CPK. CPK could be total and some fractions of CPK. There are fractions MM, BB, and MB. MM, muscle. It is fraction which is present in muscles. CPK, MM. If there is damage of muscles, we will see elevation of this enzyme. BB is brain. If there is brain injury, we can see increased CPK, BB. MB, what is it? Muscle brain. What is brain muscle?
Both them is like muscle.
No, it's specific enzyme. What is muscle, which is like a brain? Main muscle like a brain. Without this muscle,
Heart?
patient
Heart.
is dead. Heart. It's heart. It is specific enzyme for heart. So in heart disorders, we will see increased CPK in general and CPK MB. Also, we can see troponin. Troponin is cardio-specific marker. And also myoglobin. Myoglobin is present in any muscles. If there is myocardial infarction, we will see elevation of cardio-specific enzymes. In the beginning of disease, the fastest marker is myoglobin. Next marker is troponin. Next CPK-MB. And next, we can see elevation of LDH and ALT, AST. So if these enzymes are increased, patient has myocardial infarction.
Please repeat the enzymes.
Myoglobin, troponin, CPK-MB, LDH, ALT, AST. And also, as an additional marker, we can see prothrombin. Prothrombin and fibrinogen are not biochemical blood test. It is coagulation. Coagulation, why they are different tests? Because we need to use different tubes to take samples. To check coagulation, we need anticoagulative connection. Mostly we use citrate to do tests. For biochemical blood test, we don't use any additional stabilizators. But from coagulation, we can take fibrinogen like a marker of inflammation, and also we can check prothrombin like a marker of liver failure. Liver do not produce proteins, including prothrombin, clotting factors, and prothrombin will be decreased. And now let's do summary about liver disorders. In liver disorders, we can see 4 biochemical syndromes. First syndrome is mesenchymal inflammation, which we wrote before. Gamma globulins, thymol test, seromucoid, gaptoglobin, CRP, and fibrinogen. So we marked this syndrome, I think. Next, syndrome of cytolysis. In cytolysis, we will see hepatic jaundice, increased both indirect and direct bilirubin, and increased ALT and AST. Additionally, we can see LDH. Next syndrome is syndrome of cholestasis. Cholestasis is like a mechanical jaundice or some mild stage of mechanical jaundice. Cholestasis is elevation of direct bilirubin, GGTP, ALP, LDH, and cholesterol. Main marker is ALP. In Russian, our students, to remember it, repeat: щелочная фосфатаза, верный признак холестаза. Alkaline phosphatase is main marker of cholestasis. In English, it's not like in Russian. And one more syndrome is hepatocellular incompetence. It is decreased levels of protein, albumin, cholesterol, urea, creatinine, and prothrombin.
Doctor, what about globule?
Globulins will not be affected. Patient do not make synthesis, first of all, of albumins. They could be affected because of decrease of total belog, but for this syndrome, main is albumin. So hepatocellular incompetence is loss of synthetic functions of liver. Patients with liver disorders can have combinations of all these syndromes. That's why not all of markers you can see in your patient, or some markers can have a different directions in different syndromes. Example is cholesterol. In cholestasis, cholesterol increases. In hepatocellular incompetence, decreases. If patient has combination of these two syndromes, cholesterol could be normal, increased or decreased. But in other markers will be there. Alkaline phosphatase will be increased, and proteins levels will be decreased. Urea, creatinine could be decreased too. In this way, we need to do conclusion. So first of all, you need to find increased or decreased markers. Next, you need to combine them to the syndromes. And next, you can conclude. There is syndrome of cholestasis, maybe syndrome of cytolysis, and we can suspect liver disease, liver cirrhosis or hepatitis. There is elevation of urea creatinine, we can suspect kidneys failure. There is elevation of troponin, CPK, CPKMB, LDH, we can suspect heart disease. So in this way we need to do this test.
Doctor, only like increasing of the glucose is like diabetes.
Yeah. In diabetes mellitus, as a screening test, we test glucose of capillary glucose or venous glucose. Next, to confirm, we have to do additional tests. There is glucose tolerance test, and there are tests to check glycemic hemoglobin. If there is stable elevation of glucose level, glucose will react with hemoglobin, and we will see glycemic hemoglobin, and it is exact marker of diabetes mellitus. That it shows that level of glucose was stable and increased last month. So this test, if level is less than 11, just screening test. If level is greater than 11, it is diabetes mellitus exactly. If level is not so big, we just suspect diabetes mellitus.